Hello. Hello. Hi, Dr. Thomas. I'm Dr. Hetal speaking. How are you?
I'm very well, thank you. Good morning.
Good
Good
morning for
afternoon.
you.
Whatever time it is.
Yeah.
Good evening, everyone, and good morning, Dr. Roland. We are starting with his virtual talk. So it is my absolute honor to introduce Dr. Thomas Roland, a distinguished faculty member at NYU Langone Health in New York. Dr. Roland is widely recognized as one of the finest surgeons in United States, renowned for his exceptional skill and dedication in the field of otology and neurotology. His expertise is reflected in the thriving patient flow at his practice and his pioneering work in establishing a world-class cochlear implant center. And I have had the privilege to visit that. Having had the privilege to work alongside him and observe his surgical excellence firsthand, I can truly say that Dr. Roland is not only a master of his craft, but also a compassionate and inspiring individual. His combination of surgical brilliance and warm humanity makes him a role model for many, including myself. So coming to his achievements, Dr. Roland is a professor of otolaryngology, head and neck surgery, and professor of neurosurgery, New York University Grossman School of Medicine. He was chairman of the department from 2009 until 2023. He is currently the president of the American Neurotology Society. He is very active in research, clinical practice, and teaching and mentoring. He also has active projects to enhance capacity in Israel and Uganda, where he has worked for more than 20 years. He has over 300 publications, numerous textbook chapters, and is the author of 4 textbooks on cochlear implants and neurotology. Dr. Roland, we all are very privileged to have you with us. I am handing the mic over to Dr. Milind Kirtane. He is going to moderate the entire session.
Good morning to you, Tom, and we are all eager to listen to you, so you could now begin. Good morning, Tom.
Morning, Tom.
Good morning. Can you hear me?
I can hear you well. Can you hear me?
Okay, we've just given your introduction to the participants here, and they're all eager to listen to you now. So you can start your presentation.
Okay. Good morning, India. It's a beautiful, snowy morning here in Vermont, where I hope to later today do a little cross-country skiing. I wanted to thank the organizers and particularly Dr. Tanishka for inviting me to do this talk. I hope you can hear me okay.
Yes.
Okay. We went back and forth a number of times about some different topics, everything from transmastoid repair of CSF leaks and encephaloceles to ABIs in children. But we felt this topic is a very real topic. We will always, we spend the first half of our career doing cochlear for our career reimplanting them for a number of reasons. So there are some real issues and signs and symptoms. I included Dr. Susan Waltzman, who has been a colleague I've worked with for over 40 years, because we used to give a talk like this at the American Academy. For about 10 years, we'd do a mini course on this and recently stopped doing it. For disclosures, I do have advisory capacity for Cochlear Corporation. Our research team does receive research from Cochlear and MED-EL for projects that are of mutual interest. And like I said before, parts of this discussion were presented at the American Academy of Otolaryngology head next course for many years. Reimplantation becomes necessary for a number of reasons, and the first category would be medical or surgical reasons. We can have scalp flap problems, we can have infection problems, we can have electrode migration problems, there can be surgical mishaps and poor initial placement, trauma, and even receiver stimulator migration. I just had to reimplant a child who was implanted elsewhere, and the receiver stimulator migrated all the way down to and was pushing on the pinna. Quite interesting, not seen that before. This is an example of things that probably occurred more frequently in the older days, but this is a girl who was implanted at age 2, and here she is at age 5 with a breakdown over her magnet. Magnet antenna area. We're not sure if it wasn't from her glasses rubbing near the core processor, we weren't sure. It does not look particularly infected, although it is a little red. And in those days, what we would do, as you can see in the picture on the right, here's where it used to be, and we move it down to a new location. We would wash it, we would irrigate it, we would try to clean it, and try to preserve the device. I think more and more we're not preserving devices, and I'll tell you why in a minute. So what we've done for these alleged infections, is we've collected the devices and rapidly fixed them and sent them to an institution in London that did biofilm analysis. So what's interesting, this particular case was one such case, and the routine culture from the skin grew a rare staph species. But when we do other analysis for biofilms, we found other organisms such as Pseudomonas, other Staph aureus, and some other gram-positive in fact, and these are the locations. These are usually under little pouches. This is on the case, and this is by the magnet. So this kind of data was important, and this was published not so long ago in Acta Otolaryngology. And this kind of data is important because it can help the companies make devices that are more resistant to biofilms by altering the surfaces to prevent biofilm adherence. So the two kinds of analysis we did were fluorescent in situ hybridization, and we can observe where the bacteria located and visualize the bacteria, but not much information about diversity. Then we can do 16 RNA sequencing, and we can figure out what the bacteria are, and sometimes retrieving can be challenging. And these are just some more examples. This was an implant infection, and again, the location of the biofilms were under the magnet area and by the coil. Another one with similar location, a little bit at the lead takeoff as well. This is a device that was implanted for just being a poor performer, no infection. But interestingly, we did find some biofilms on the device. This patient had elective explant because they weren't getting benefit and went on to an ABI. The patient did have golden hair syndrome and cochlear nerve deficiency. Had one year of the implant being in the head. So sometimes biofilms can get on things. It's particularly interesting in orthopedics, but we don't without clinical infections. Another implant failure, hard failure, explanted, and the device did sit around for 4 days before it was placed in a fixative. So maybe this was just a contamination. But again, you can see biofilms by the stimulator plate. I am out of interference. I wonder if people could mute their microphones. So overall analysis on 21 devices that we analyzed that and where the location was. So in the pocket where the extracochlear electrode on the case was, in the magnet pocket only. These are all the different places of these devices. These were the freedom devices in those days. Interestingly, we did not find any biofilms in the middle ear portion of the electrode or mastoid portion of the electrode that were biofilm resistant for some reason. So in our final analysis is that wound culture can often be different than the biofilm analysis. Sometimes if you're going to treat these patients, the wound culture may not give you all the information that you need. We think it's important to look at these devices so manufacturers can alter the surface of the devices to prevent biofilm attachments. Pouches, such as around the magnet, should be minimized if possible. And it is important to send these devices for analysis if you have the capability so we can continue to understand this. The other reason we do cochlear reimplantation is for devices such as hard failures where you don't have sudden failure, no sound or abnormal sound, or soft failure, which I call a pre-failure. And that we usually detect by our regular evaluations. If their speech discrimination score is normally around 85%, and suddenly they're down at 70, and then we bring them back and put them on the radar down to 60, we start thinking the device is beginning to fail. And these symptoms can be subtle, just decreased performance or perception, even not achieving expectations. You know, an older, a middle-aged adult who has progressive hearing loss who gets implanted relatively becomes a cat, he or she may be a great performer. But if they're not, then we think about something wrong. Sometimes pain or discomfort, static. Hearing is off. This is interesting because I used to people that tell me they hear things when the device is not on their head, when the processor is not on their head. I used to think maybe I should get a psychiatry consult, But actually, what I've learned is if there's hermeticity issue and there's moisture in the device, the device can actually power itself. It acts like a battery and can actually cause sounds. So I take that more seriously. And then the poor performers, the people that get much, we all know there are some people that we expect to be poor performers or performance might not be stellar, but those that we expect to have good performance and don't, we also think about device related issues. So when we suspect a failure or a failure gets sent to us from another institution, the first thing we do is I send to technology for troubleshooting. Sometimes just reorganizing the map or different creative mapping techniques, we can get them performing well again. So we review all the prior results, the maps, the surgical notes, the imaging studies, and we evaluate the patient. We check the maps, check eyes, do creative programming. The companies can each do device-specific integrity testing to tell if there's a problem in the device. And I often get new imaging or sometimes imaging, the first imaging. It's amazing to me. I get patients that's been sent to me for evaluation who have had trouble for a year, and there was never an image done, either intra or after operation. Sometimes, surgeons can be stubborn people, and they say, it's not me, I did everything right, everything's perfect. An image and the device isn't even in the cochlea or it's wrapped around, bent on itself or whatever. One thing that's a pet peeve of mine, you don't need, often people's first knee-jerk reaction is let's get a CT. Denver's view mastoid series, I contend, can give you more data than a CT, or often all the data you need to see about a device placement. So in terms of reimplantation, once we made the decision to reimplant, not every infection requires explantation, but I would say in our practice, we would sometimes, do a washout, clean up, wipe the device down with alcohol or whatever, maybe put some sprinkles, some vancomycin powder in there, do all of our tricks, put them on IV antibiotics. They look good for 3 months, and then the biofilm flares up again, and they get another fistula. So more often than not, we now probably explant more for infectious purposes. But when you remove the receiver stimulator where these biofilms exist, but leave the electrode in the cochlea, it keeps the patent. If you take the electrode out of the cochlea and there was an infection, you can get fibrosis and even calcification. So when you come back in 3 months, it can be very difficult to get a nice insertion. So you make a hearing patient into a non-hearing patient again. So always cut the electrode off at the cochlea and leave it there. Then you reimplant after the infection clears. The routine at our center has been 3 months. I'm not sure if that's based on anything, but we let everything clear up and go back in and reimplant in 3 months. It is important to consider electrode choice. Devices change over time. So you don't want to put a small reinsert with a larger diameter electrode into a smaller diameter lumen. So it's important to think about that, what you're reimplanted with. And the other thing to keep in mind is that cochlear reimplantation can represent an obstructed cochlea situation, especially if someone didn't leave the electrode in the cochlea. So you have to be prepared to do drill out techniques and other techniques. Something we've been doing more recently, we're working on a project in regular cochlear implantations with apical low frequency hearing. So you would have your electrode in the basal area, and then you drop the ground electrode into the apex, and then you can stimulate between this electrode and the apex and get more sound. We have used this in obstructed cochleas lately because there are no more double arrays, or a double array has to be special ordered, which can take months to get. Isn't good. The other issue that we sometimes have encountered and that some people have talked about is perimedullary electrodes are more traumatic to remove than outer wall electrodes, which isn't true. And was not that feeling was not based on any real data. So here's a model that we and this is another published publication from 2 years ago. We filled a 2D cochlea with a gel that simulated soft tissue for an outer wall electrode and a perimedullary electrode. And then we withdrew these electrodes slowly and measured the forces that it took to withdraw and also observed the electrode behavior. So the perimedullary electrode kind of just slips right out and does not displace the tissue, which you'll see on this image. But the outer wall electrode you'll see does displace the soft tissue more immediately. It's kind of like the capstan effect and the reason we wrap a string on a sailboat around the sailboat cleat is to get more friction. So here you can see this just slides out nicely, but here you can see electrode as you pull on it, pushes the soft tissue more medial toward the medulla. So there is more soft tissue disruption with no soft tissue disruption. So it is important to think about explantation and reimplantation. I personally am a very big believer in perimedullar electrodes for a lot of reasons after 20 years of study, and this is just yet another reason why. This is a patient who had affection, and the surgeon inadvertently put out the electrode. And when they did imaging, they saw that the scala tympani was ossified. This just is 2 months later going back in. We thought we could see a little bit of a lumen on the MRI and the scala tympani. So here's it's a left ear. Here you can see the normal cochleostomy position, and it was all full of scar tissue. So we moved a little bit north toward the oval, and we broke into a little lumen for a scala in this patient, and she did quite well. We published some data in 2006 on this topic of intentional scala vestibular insertions. I think there probably were a lot of scala vestibular insertions over the. I actually think for the first 10 to 15 years of cochlear implantation, but a lot of electrodes right into the scala vestibuli. The very deaf patients in those days did well. Here's another example, which is something I'm also very concerned about. When we implant severe malformation, so this is a girl with a hypoplastia on the right side and no cochlear. Got about 6 or 5 electrodes in the map, age 2, some modest results. She had a device, unfortunately, 6 years later, and this hole was calcified and scarred in. And so at reimplantation, they could only get 1 electrode in a lot of facial stimulation, and she was regressing. So referred to an opinion. So my first thought was maybe we should try. So one of the problems with malformation is the neuroepithelial element not in the cochlea mostly, and fibrosis and ossification occurs. And removing an old electrode, you might just pull out all of the target cells that you're trying to stimulate. And so what I did in the first attempt was I just drilled a little circle around the center of this cochlea, and thinking maybe laying some electrodes not within the cochlea, but around the side, I could get stimulation. But this failed miserably. She got facial nerve stimulation, no auditory percepts, and then she went on to an ABI. This is just an example of what a cochlear nerve deficiency looks like, an ABI placement. She was 9 at the time. See her old, rather large cochlear implant incision. This is interesting because here's the lower cranial nerve. Here's the wisp of an 8th nerve. This is really what cochlear nerve deficiency looks like inside the head. Normally, the 8th nerve is about the size of the 9th nerve. So I view this as sort of like a poor internet signal. And here we see we're putting the ABI in a nice location. And she did, this is this cochlear nerve deficiency. I didn't realize at the time that I had imaged a cochlear nerve deficiency. This is what the ABI paddle looks like on an X-ray. And she actually did quite well, better than she did with her first initial poorly functioning cochlear implant with good thresholds, and some of the mother's comments about her being a happier child and identifying sounds. So when you reimplant malformations, counseling is very important. Maybe we need to think about different electrodes at the first implantation, like electrodes to prevent fibrosis. I also personally feel that we should push the companies to continue to develop ABIs and have us get better and better with them. By the way, NYU will host the 5th International ABI Conference next May 2nd and 3rd in 2025. And coming, email me and I'll send you the announcement and the abstract situation and where you can register for the meeting. Companies should continue to advance ABI technology, because I think when we reimplant these somewhat poorly functioning cochlear implants in malformations, they may not get something on the reimplantation and therefore might have ABIs. I think we're going to see a bump in numbers over time. Some considerations when you're reimplanting: generally stay with the same manufacturer. There are processing issues, so every company uses a slightly different processing strategy. We do have many patients with 2 devices. The device replacement is covered by the manufacturer. So if they have 2 devices, you don't want to put a Med-L on one side and a cochlear on the other side, and I think you want to stay with the same company on both sides, although I do know of a few patients that have different companies. I always make sure that I send the audio a picture. So I produce something like this. This was an apical that was obstructed. So I was able to get, I think this says E6 is at the cochleostomy. So 22 minus 6 is 16. So 16 electrodes in and the apical electrode. And this lets the audiologist know what electrodes to use and not to use. They certainly don't want to put extra cochlear electrodes into the map. Some patients decided I've confidence in a company and I want a different company. That becomes sort of a financial legal issue, but in general, the companies have been doing that transition. So reimplantation technique, we usually use the same incision or smaller. We cannot use monopolar cautery, so we use the Shaw heated scalpel. It's just a hot scalpel blade where no current passes through the body. We don't want current to injure the device, which is going to go back for cause analysis. Won't know it's covered. We open the subcutaneous flap over the device capsule. We open the capsule. We cut the tie down suture. We dissect the electrodes somewhat anteriorly. You do not have to dissect out electrodes. You can just cut them off, and you'll see I make two cuts. My first cut is the electrodes as they enter the mastoid. Company can cause a fit. In the old days, we thought we had to dissect out the ground wire, the full electrode, which you do not have to do. So we remove the receiver stimulator. We try not to squeeze it or traumatize it because we want to return it for electrodes we cut off for cause of failure analysis. I'll revise the seat or the well. If it's a different device, sometimes device sizes change. If a newer model cochlear implant is used and there's a different size receiver stimulator. Raise the anterior flap, then I'll find the electrode going through the facial recess and I'll make a second cut there. And like I said, there's no need to dig out the free ground electrode. You can just cut it and leave. I'll revise the facial recess. The idea here is you want to not let whatever the first surgeon did determine your approach. You want to really revise it, be careful not to extract the electrode from the cochlea prematurely. You want to just get really good exposure for this. This is really important to get it just right. I'll irrigate the blood and bone dust. I'll secure hemostasis. Then I'll open the new device and I'll place it in the well and tie down hole and place the free ground and remove. The last act of surgery really should be the removal of the old electrode and put in the new one. You don't want to do that first and then have to futz around with the receiver out of place. That could be a problem. I always say to the fellows and residents, keep your eye on the ball. It's like learning how to play tennis. So replacing electrode should be the last act of the process. You then pack the cochleostomy, we get a good intraoperative x-ray, and we do some monitoring. So this is just a sequence of events. Here's the Shaw scalpel. It's just a hot blade. I'll make flap and elevate it. I'll find the electrodes going into the mastoid. I'll cut them off there on the receiver stimulator. We'll elevate it out of the package. I want to revise well for putting in a different size and shape device. Get all that done first. We start looking down at the mastoid and we find the electrode going through the facial recess. Revise this trough. And sometimes we make a little what we call the midtown tunnel, which protects the electrodes as it enters the mastoid. And then here you can see I'm cutting the electrodes off. Revising the facial recess, get a nice good view. The electrode is still sitting there in the cochlea. And then you get the new device back in its receivers, the receiver stimulator in its position, load the electrode. This was an advanced bionics device and an inserting tool. And then we're going to gently get all prepared. We're going to remove the old electrode and gently insert the new electrode and get a nice full insertion, hopefully, then close the flaps. And then we do our intraoperative testing and our x-ray. I get, for bilateral implants, I'll get one plain AP view. And for unilateral implants, I'll get a, what I call an anti-Stenberg view. I'm still getting a lot of in the background. If people could please mute or stop talking, that would be helpful. Is there some way we can stop the chatter? I can't really hear. All right, I'll try to proceed. So we looked recently at some reimplantation data at NYU. Our failure rates have overall decreased from a reported 6 to 15% in the literature, which is about point. The AB field recall plan, field action plan, and a lot of that has to do with improvement in implantation techniques, improved manufacturing quality control, and also manufacturers responding to our cause of failure analysis. In other words, if a certain type model of device has a certain number of failures, Then in the next generation, if they can figure out why that failure occurred, which is almost always a hermeticity issue at where the electrodes come out of the device, they can fix that and build that out so the next generation should have less cause of failure. Most studies in children and adults have shown that post-reimplantation performance is usually equal to or better than pre-implantation. However, there was one study that 30% of the patients did not give as much benefit as the old device. So we looked at a retrospective chart review over a 1-year period. Dr. Chithanamith and Dr. Winchester, who's a resident, have submitted this for publication. We used intraoperative x-rays to assess the original vision insertions, and we did age-appropriate performance measures. And this is kind of what an x-ray might look like. And then they'll do some analysis to get a sense of the depth of insertion and its relative location in the cochlea. And this is just this just shows the original implant was 470 degrees and the reimplant was 414 degrees. So in this case, we got it a little bit deeper than the original implantation, maybe a different device. So we looked at 68 revision cases in 54 patients. 61% were male, 57% were pediatric. The median age was 19 years. The median age in children was 3.7 years. And the median time between original surgery and revision was about 2 years. We had 31 heart failures, 20 of which were due to the AB field action plan. 31% were medical or surgical failures. 5 or 7% were soft failures, and one was just a sequential revision. In other words, revised twice. Someone who unfortunately got a device and then got a reimplantation with another device that was prone to failure. So, excuse me. We found is that the original electrode insertion depth was not significantly different than the revision overall. So for the hard failures, the original depth was 392 degrees, and the revision was 393 degrees. Medical surgical failure, again, about the same insertion depth, and the soft failure is about the same insertion depth. Also, our data shows, was somewhat limited, but shows equal post-revision performance in adults and children. Just because you get a new device with new bells and whistles doesn't mean you're going to get a higher performance. I've had many parents come to me when the child has a 10 or 15-year-old device and says, when can I get that new device? And I always say when the device fails, because it's not guaranteed. There was maybe a slight kick. It wasn't statistically really significant in the kids group in terms of performance. That might just be because they're older. So when in terms of device electrode failure, 49 or 72% were revised with the same device and the same electrode. 6 patients, or 8.8%, were revised with a different manufacturer. And of those, the electrodes, same manufacturer, different electrodes. So 4 from a legacy device to a modern device, 2 from a short electrode to a longer electrode, and 7 went from slim modular to a slim straight electrode. And the patients that had the same device and same electrode, average time from original surgery to revision was 1.8 years. Again, similar insertion depths and similar performance. For those that changed manufacturers, again, similar, slightly more and better insertion depth, but not that statistically significant. And performance actually went down, also not really statistically significant because of the numbers. If you change manufacturers, some went from the AB mid-scalar to the Contour Advance. One patient went from the AB mid-scalar to the Slim Straight. Also, some went from the Slim Modular to the Med-L Flex, one patient. And for the 12 patients that changed an electrode, median time to revision was 2 years. Again, slightly less, but similar insertion depth. And then the legacy devices. So devices will fail. So this is the 40th anniversary of the NYU Cochlear Implant Center this year. And so we had a lot of these original Cochlear devices that we implanted in the 80s that are beginning to fail. Some 4 patients in this study, 3 went to the Contour Advance and 2 went to the Slim Straight. And performance was slightly less with the device, but again, not statistically significant to the small. We do have that we are high there here to go on to longer devices for performance went one went to contour advance and one went to the slim straight electrode. The medullary electrode, if dialer in, is a good in terms of it working properly, but some have to move contour slim in most cases. This electrode will actually follow the intracochlear path and look like a pyramid electrode if you place it. Vision insertion and performance is similar, and when possible, we like to replace like with like. So some of the complaints in these device failure group is sudden failure, no link, poor performance, sound detection or pain at a very low level, need for very programming. You can program a patient, it sounds good in the booth, they go home and the next day they say, oh, it's terrible again. Pain's important. Pain can present a heart problem if you don't find any other reason, if you're unable to program the device. So I looked at over 220 cause of failure analysis. I was trying to correlate symptoms to what your mode was. In other words, did a certain symptom indicate a short circuit or damage? And I really couldn't find a great correlation. So all kinds of symptoms can occur. So in summary, we want to pay attention to the patient's symptoms. We want to pay attention to regular evaluation results. In other words, a drop in for performance can be an early sign of a device failure. We have some objective measures. We want to pay attention to these unexpected poor outcomes. The patient they expect to do well, it isn't. We want to do a careful and thoughtful evaluation process. Imaging is still very important. I'm really always surprised at how many patients come to us that have just been doing poorly at another center for years and no one ever got an X-ray, and then we get one and the answer is usually pretty obvious. And then careful and thoughtful surgical technique is essential and can assure success. So it can be reimplantation can be performed without a decrease in performance, but not always necessarily. So patients have to be counseled. Increased speech understanding is not guaranteed despite reimplantation with the newer technologically advanced devices. Newer is not always better in a given individual. Adjustments take time. Sometimes patients get their new device. It sounds different. It may be a different frequency allocation table, which one of our researchers, Dr. Swirsky, is working on. And my other statement would be that infections are sometimes hard to treat without device removal. In the old days, we did everything we possibly could to preserve devices. And now I think it's much less expensive and better for the patient to remove it, come back in 3 months in a sterile environment, put in a new device. So thank you very much for the invitation again. Thank you, Tanishka, for inviting me. And I'm happy to take any questions that people may have.
Yeah, thank you, Tom. Thank you for a very concise lecture. And we just, one question, could you sort of enlighten us a little more about the apical placement of the ground electrode? That's something new.
I'm not hearing the question very well. Maybe
the apical placement of the ground electrode. How do you
there's reverb in the room. I understand the speech, but maybe.
Sorry, can I try again?
I could answer.
Could you please tell us a little more about the apical placement of the ground electrode?
Understood. Coming microphone reason.
Tom, did you get me? Can you hear me? Tom, can you hear me?
I can make out every word. It's all very reverberation. Sorry.
I'll say slowly.
Okay, now it's better.
Yeah. Tell us a little more about the apical placement of the ground electrode. When and how?
Oh, the apical placement. So this started some years ago. We had an idea. There's this controversy or battle, I guess, between very long electrodes getting to lower frequencies, and perimedial electrodes don't have to go in as deep to get the same neurons, and where the actual neurons that we're trying to stimulate actually live in the cochlea. And also the more apical neurons are all come into a bundle, we've learned from some recent data. And so it's hard to get spectral. Dr. Landsberger said to me one day, do we really need to put a long electrode all the way in there and have a lot of contact up in the top of the cochlea, or will one do? And he's under the impression that just having one on the top of the cochlea. So our idea, and we got an FDA approval, an IDE, and also an NIH grant to do 25 patients, and we're probably about halfway through that. And these are just regular cochlear implant patients that don't really have residual hearing, and we're putting a regular perimodal electrode in and then putting the apical electrode in. And I'll tell you how to do that. I could probably even show you a picture maybe. And the idea is to give them, you can make some low frequency signals, then making a channel where you electrode apex, to apex, and we're actually getting some nice results. People are pursuing lower frequency sounds. They're doing better with appreciation and also hearing and noise. We have a couple publications on that. Some more shortly. Good results.
So, where do you place it, and how do you fix it into position?
I'll show you. So one day I was doing cochlea, post-meningitic cochlea, and all was 8 electrodes in basal turn with a drill out. And I said, well, this apical thing seems to be working. We don't double away. So I might as well just do my apical electrode. And so, and that patient actually now has something like 15 channels in their map. In the old days, we did double arrays, but I think we were programming them incorrectly. We were like a regular cochlear implant from inside the cochlea to the grounds, rather than in between and another electrode in the basal turn. And I think that we're now going back to the array patients and trying some different programming techniques. So how I do, when I do the facial recess, I take out the Inca, I open up the facial recess widely, sort of a top-down facial recess, take this bar, put them, and then you go over the stapes. We actually have 2 publications about how to place this with some and videos, but and so I go anterior to the cochlear process, insert with one diamond and drill a little dip into the cochlea is quite thick there, and then you push the ground electrode in all the way, and then it can be fixed because the malleus is just lateral to it, so you can wedge a piece of soft tissue, and you're shorter. You have to stimulate a little bit closer, just nicely. You'll bear with, go back and share.
Tom, we are not hearing you clearly. Can you switch off your video? Just give us the audio.
Oh, I was going to show you the.
Okay. We would like to see that.
Hold on, let me see if I can get back
to screen sharing. Yeah.
There. This. Let's see if I have desktop. And let's see if I have the apical electrode there. Probably do. This movie?
Yeah, we just have the screenshot here. Your laptop screen. Yeah, now we got the movie. Yes.
So there you see, I took out the incus.
Yes.
I took down the incus bar. This is the cochlear aeriform process. I'm in front of it, behind facial, the nerve. You gotta be careful. The stapes is back here.
Yeah.
And now I'm just breaking into the apex. The trema. There are really no hair cells in the helicotrema. So I use a little McGee rasp, and that's about a 1 millimeter opening.
Okay. How deep?
Then I go, well, you just break into it. You break into the lumen, and there's the free ground going into that lumen. Goes quite nicely, kind of stays there nicely.
So you're going into the lumen of the cochlea.
Yeah, it has to be inside the cochlea. It cannot be on.
Oh, okay.
Which is when you're hearing it happen inside for actually.
And this is a little in front of the processus cochleariformis, anterior to it.
And just under the edge of the, You can look in our publications and see it more. And then I'm putting in the electrode regular cochleostomy, the 632. So in a case where you have to do a little bit of a drill out, using the magnet and the electrode, it stays very nicely in place. Hold it in there nicely. And that's kind of what it looks like. And that now you can have stimulation between electrodes in the bottom of the cochlea and get frequency.
So when you do a drill out for the ossified, do you use the lateral wall electrode or do you use the 632?
I do for an ossified cochlea. This was not regular cochlea, but no, there's no point in using a 632. You just get whatever you can in there. Sometimes I'll use for a fibrotic or ossified cochlea, I'll use a 612, but leave the stylet in because it's a little bit stiffer and you can push through things. Usually you drill to the corner and you see you can get around the corner. Sometimes the lumen will be open and you can get a full insertion by getting around the corner. Sometimes not. So if I'm getting a small number of electrodes in the basal turn, I'll consider putting this into the apex, which will just give programming audiologists the ability to maybe get more channels. We have some good examples. I have a child from Texas came to had an situation, got a bad infection, applied his cochlea. By the time they did the implant, they only got like 12 or 10 electrodes in. He was not getting understanding. They came, they heard about this and said, and I said, well, we should try this. I said, I can't guarantee anything. So I reimplanted with 6-1, but I think I got an electrode, they turned my electrode in, and that has 15 channels.
Okay.
And he can pitch match, and he now has open set speech understanding. So he went from somewhat of a cochlear implant disaster to at least very happy or doing better with his cochlear implant.
All right, Tom, thank you very much. It was really very patient of you to stay with us till we got you connected. But it's been a fabulous presentation, and we are all very grateful to you.
Well, thank you. Thanks so much.
Okay, so we're closing the session. Once again, Tom, thanks a million.
All right.
Enjoy your
Welcome.
skiing, and
Thank you.
maybe send us some nice photographs.
I'll try. Okay.
Take care. Bye.
General body meeting. We are starting in the same hall immediately. Please be seated.